I'm delighted to introduce Dr. Gillian Wright. Dr. Gillian is a medical doctor who trained in hospice medicine and in palliative care. In 2018, she changed sphere into the medical ethics field and worked with the Scottish Council for Human Bioethics until 2020. And she now works for the campaign group Our Duty of Care, which opposes the introduction of assisted suicide and euthanasia into the UK. So Gillian, very pleased to have you, and thank you for being here and being able to talk to us this evening.
Thank you so much, Paul. Thank you for your kind introduction. It's a real pleasure for me to be with you all this evening. And I'm really grateful to be able to share with you my perspective about the current assisted dying debate. I just wonder, can everyone else see slides just now? Are they coming up? Not yet. Hopefully they'll come up in a little minute. Brilliant. Thank you so much. That's great. Firstly, what I wanted to mention was a few thoughts by way of introduction about what dignity in dying really is about, and then outline what we mean by good palliative care, and then come on latterly to mention assisted suicide and euthanasia, particularly with respect to some international perspectives. And then finally, I hope we'll be able to have a really helpful discussion about some of your thoughts about how this might affect Scotland. And in this context, I'm really conscious that this is a personal and quite sensitive topic. And so I do appreciate there may be some of you who are listening tonight for whom this is not an abstract issue, but it actually relates to your family or your situation. And I would really urge you, Zoom seems such an impersonal medium, doesn't it? And I would hate for anyone to be anxious or upset tonight because of this particular discussion. So if you are affected by it, please do find someone kind to talk to, and I'm sure Paul would point you in the right direction if you're looking for that. So most of you will be aware, I think, that Liam MacArthur, who is one of the Orkney MSPs, has announced that there is going to be an assisted dying bill, which is going to go through the Scottish Parliament. Maybe I could have the next slide, if you can. Now, those of you who are extremely awake will note that this is not Liam MacArthur, but it's actually Patrick Harvey from the last bill. But I just like to sign, dignified dying is a human right. And I think this is a really important concept. Decision making at the end of life is really important for all of us. It's important for patients, it's important for clinicians, and it's important for society as a whole. And I think perhaps just so everybody's clear what we're talking about at the moment, the campaign, which is being launched by Dignity in Dying and is culminated in this bill that is going through the House, going through Holyrood, is for what we would think of as assisted suicide. So the doctor prescribes a dose of lethal medication to a patient who is terminally ill, usually in the last 6 months of life, who has the capacity to make a decision and is acting in a voluntary capacity. So what we mean as assisted suicide. Euthanasia is slightly different. That's when the doctor actually administers the medication to the patient. But what Liam MacArthur has suggested is that we would have assisted suicide, and he has called that assisted dying because it refers to the dying phase or the last 6 months of a patient. And absolutely, let's go on to the next slide. What I want to think of just for a moment is, what is dignity? I think most of us know intuitively what we imagine when we think of dignity. We think of a dignified person or a dignified situation, but it's actually quite difficult to distill what is dignity in and of itself. And I thought that Pope Francis put it really well when he described the difference between things and people. So here he said, things have a price and can be sold, but people have a dignity. They are worth more than things, and they are above price. I thought that was particularly helpful. I think many, if not all of you here tonight, might be from a Catholic background or tradition. And there is a sense that Catholic teaching is very clear that individuals, human beings, have value and worth. They have dignity because we are made in the image of God. But dignity is also found to be important from a secular perspective as well. And if you consider something like the United Nations Declaration for Human Rights, that recognises in its preamble the inherent dignity of individuals, of human beings. And that dignity is the foundation of justice and peace and freedom throughout the world. And actually, human dignity is the reason that we prohibit intentional killing. So my question for you tonight is, how best can we manage, how best can we look after patients who are at the end of life? And I think it's really important to dwell or to listen to the fact that many people are asking for assisted suicide. There is a campaign, and I think we need to recognise that there is a small minority of people who are asking for this, and that they perhaps have had difficult or distressing experiences at the end of life. And we do need to respond to that. But I think there is a good alternative to assisted dying. I think we don't have to respond by taking life, but rather we can respond as a Scottish society with excellent and well-funded palliative care. Next slide, please. So one of the things which is really important is how to help medical staff, nursing staff, to treat people with dignity so that we perceive that end-of-life care is dignified and we don't have to resort to assisted dying. And there is a psychiatrist from Canada who's described something called dignity therapy, and he, Dr. Chochinov, but actually it's not even as complicated as that. It has been at the essence of good palliative care for many, many years. So next slide, please. If I was asking questions, I would ask if anyone knew who this lady is or who this lady was. And I think many of you might recognise her. She was Dame Cicely Saunders, and she was really the founder of the modern hospice movement. And she was a fantastic lady. She initially trained as a social worker, and then a nurse, and then finally as a doctor. So she was actually a whole multidisciplinary team rolled into one. But she pioneered a different approach to looking after patients at the end of life, which encompassed a holistic management of care. And she talked particularly about 4 different aspects. The first was physical care, and that's what we understand in terms of managing things with medicines particularly, but also psychological care, so looking after patients when they're anxious or depressed. Thirdly, looking after social aspects of a patient's illness. So how does it affect how they relate to their children or to their parents? And finally, a really important aspect, which is spiritual care, because at the end of life, we all have thoughts of purpose, of meaning, of value, and wonderings about what our life has meant and been worth. And so spiritual care is actually a really important aspect to everything that all healthcare professionals in palliative care do. Next slide, please. So this is a really old painting, over a century old, and it was really just to break up the text in a sense, but also just for us to think in terms of illness and dying is in the context we're not just a patient in a ward, we are people in a family scenario, we're people in a community, and the doctor who you can see struggling to work out what is going on with this little one, it also has a responsibility to her mum, who you can see is really distressed on the other side of the picture, and her dad, who's looking on in concern. And you can see all the things that they've tried round about. So we're not just patients in beds with numbers and charts. We're people with lives and families. And I think I worked in palliative care laterally, but I worked in general medicine to begin with. And I think one of the wonderful things that I experienced in palliative care was the sense of looking after the whole person, rather than simply just another emergency admission. Next slide, please. And one of the concepts which Cicely Saunders took to a different level was the sense that people might have what we call total pain. So it wasn't just that pain, for example, when somebody might have broken a leg or they might have pain in their leg. There's a sense that people might have pain or distress because they're not sleeping well, because they're anxious about who will look after their family when they die. There might be some spiritual angst. Why me? Why has God let this happen to me at this time? There may be guilt or regret about things that have happened in their lives. There may be psychological concerns, so anger. I remember looking after a man who was desperately angry at what had happened, about the loss of his job, about the loss of who he was as a person. And his pain couldn't just be resolved by managing with morphine, but it was so much bigger than that. Often there is disfigurement, so patients with difficult tumours have disfigurement of their face or bodies, and that's difficult for them to come to terms with. And I think there's very understandable fear. And this, I think, can be particularly when chaplaincy has an extremely important role, and dealings with anxiety about what might happen after death. The chaplains are a really important part of the team. So I think it's important not just to deal with medicines and painkillers, but really to deal with the whole sense that a patient might be distressed in a number of ways approaching the end of life. Next slide, please. So this is one of my favourite places in the world. You might not recognise it, but this is the day room or the reception area of the Macmillan unit of the Royal Bournemouth Hospital. So many of you may not have been to Bournemouth, but this is where I started doing palliative care. And I remember many, many occasions sitting on those rather terrible brown chairs, talking to families who'd come in and explaining that their relative or loved one wasn't well. And it was a place where you could deal with physical symptoms. The drug cupboard is just round that corner, but it's also a place where you could talk to families and where you could hear about their struggles, what was happening at home, and all sorts of different things that were going on. But there are lots of aspects to physical management that are incredibly manageable. So I just wanted to, in some ways, allay some anxieties. There is lots that we can do. So different ways of managing difficult nausea with medicines, difficult symptoms such as breathlessness. These are symptoms which you can do lots of things for. And although sometimes people say in hospital, I'm so sorry, there's not more we can do, so we're now referring you to the hospice. Actually, that's when palliative care starts, and there's so much that can be done at that stage of an illness. Next slide, please. So this is really not for you to be concerned with the detail, but really just so that you have a sense that there is some detail and that we have a sense of there being a ladder of pain management. So patients have mild to moderate pain. We start off with basic painkillers, paracetamol and brufen. Then you work your way up the ladder with codeine and tramadol. And then towards the end, you're starting things like morphine and morphine analogues, which you can see later on. But just to say, there's lots of different types of morphine analogues. There's different things we can try. There's different doses we can try. We can titrate them to the pain and also to the side effects that people are having. And also there's lots of other medicines that you can use for pain. There's steroids. There's different medicines that you can use in this situation. And also there's different ways of managing pain. So if somebody has bony pain, you can manage that with a single dose of radiotherapy. If somebody has a bony fracture, you might want to pin the fracture via a surgical procedure to reduce the pain that they have. And also just to manage other symptoms. So pain is usually worse if you feel sick at the same time, or if you're feeling breathless, or if you're anxious. So different ways of managing these types of symptoms are ways of managing pain at the end of life. Next slide, please. So just by way of explanation, there's all sorts of other roles in the hospice. I think if you look to the left-hand side, there is usually a day unit associated with a hospice, and art therapy is very commonly used as a way of providing a creative outlet for people to express how they're feeling, and also just a sense of solidarity. So people make friends, they experience companionship while doing an activity with somebody else that is able to come alongside them. And often hospices have great gardens. There are some beautiful gardens that have been in different hospices that I've worked. And I remember working in a hospice in Portsmouth that had beautiful patio windows and doors for each patient. And outside there was a bird table, and each patient had a bird book so that they could watch the birds as they were lying in bed. So there's so much opportunity for thoughtfulness and compassion in the way that you look after people, even just thinking about the environment and also the things that they can do. But I want, just by way of explanation, just to make a comment, is that hospice is not all we mean by palliative care. In actual fact, it's only one part. And there's also important teams. The specialist role is in the hospice, but there's also a role for a specialty team in the hospice, in hospital rather. So if you, for example, are in the Beatson in Glasgow or the cancer unit in Edinburgh, there will also be a palliative care team based in the major hospitals there. And so they're will be able to go out and visit you on your ward and help you with pain or nausea or different symptoms that you have, and also help you with psychological support while you're having treatment, for example, for chemotherapy in the oncology wards. So that's a really important aspect to non-hospice palliative care. But perhaps one of the most important aspects is that which is done by GPs, and I'm not sure there might even be GPs here tonight, but GPs and district nurses do an enormous amount of palliative care, and they are the community team, if you like. So they are involved in prescribing, they're involved in support, they're involved in helping with dressings, bandaging, with supporting families, all sorts of ways. General practice is involved. And so from a generalist role to a hospital role to a hospice role, there are actually really 3 different teams who are all working together at different stages of the illness. And you can be involved in each of those at different times of your illness. So you could be admitted to the hospice for perhaps a fortnight to manage your pain and then get home, and the GP and district nurses would see you at home. Then you might go into hospital, for example, for an acute infection, and then go home again, and then go into hospice again for end of life care. So hopefully that gives you a sense of the way that palliative care can fit into end of life care management. Next slide, please. And just by way of a final thought, palliative care is uniquely placed to help patients and their families think about what's important to them at the end of life. And so it's really helpful and important, for example, for patients to think, would they want to go back to the hospice, or would they want to stay at home? For example, if they deteriorated, would they want to go back into hospital if they became unwell, or would they want to stay at home? And those sorts of wishes and preferences can be expressed to the GP or to the Macmillan nurse and to be recorded. Into that context comes planning such as resuscitation, and when that's the right time to do that. So all sorts of plans can be made at home so that patients' wishes are taken into account. So it's really important that that's part of planning, so that patients and their families know a little bit about what's going to happen next. And I think I've found that one of the most rewarding aspects of working was to be able to explain a little bit of what's going to happen next, even if you can't imagine everything. It does help people to plan and to understand, and to be less anxious about what the next stages might involve. Next slide, please. Thanks. So I think one of Cicely Saunders' great quotes was that you don't have to kill the patient in order to kill the pain. And she was just a pioneer in trying new techniques, trying different ways of managing patients, of looking after patients to the best that she could so that they could live until they died. Next slide, please. And I think that brings us, in a sense, to look at what assisted dying might involve and why we might want to oppose it. Firstly, there are what we would think of as duty-based arguments, or arguments from a religious or Christian perspective. Firstly, that we would hold life to be sacred, or that it's we would oppose the intentional killing of precious human life. And we do that because human beings have inherent value and worth, and that we would hold that higher than individual patient choice. So that would be our kind of intrinsic opposition to, or the sanctity of life argument. But there's lots of other arguments, and they're on the next slide. So even people who do not hold that view, so who may not hold the fact that our lives are under God, they can and do oppose assisted suicide because of all sorts of consequential problems, all sorts of adverse effects that assisted dying or assisted suicide cause in our society. And I've just mentioned a few of those on the slide. Firstly, I think it really undermines the doctor-patient relationship, which is crucial that patients trust their doctor. It's important that when they know you, that they know you're not going to kill them. And I think people are anxious anyway at the end of life, and they need to have a sense that you do what you do to protect them rather than in any way to harm them. I think this is particularly for those who are most vulnerable. And I think one of my concerns is that those who are campaigning for assisted dying tend often to be the most articulate and educated in society. And it's not the wishes of those who are on the wards. Certainly my experience was that it was very, very rarely asked for. And the vast majority of patients, it wouldn't have been something that they wanted. I think thirdly, it's really important that this may not be the actual wishes of the patient. Transient thoughts of worthlessness or hopelessness are actually quite common. And so people do have a sense of this is too difficult to cope with, and I don't want to have to go on in this way. But with really good palliative care, you can give people the sense of hope and optimism that they can go on. And I suppose I think particularly of older man, he wasn't very elderly, that I remember finding on a surgical ward when I was doing respiratory medicine, and he was diagnosed with a lung cancer, which is very, very common in Scotland, very particularly common in the west of Scotland, and he had very advanced metastatic lung cancer. We gave him some chemotherapy, and he just wasn't going to do. But he was interesting. And I think I remember him particularly because he was quite a modest man, and he had really no family at all. He was estranged from his son. And I remember because he told me he had had a time in prison. And I don't know whether he felt he ought to tell me or if it just was something he wanted to talk about. But he was estranged from his family. And he had obviously had interests and talents. I remember he told me that he'd cycled around Ireland in his prime. I remember that. And I remember when it came towards his frailty. And I remember his second or third lot of chemotherapy really just, it was too much for him, and he became very unwell. He had a serious infection, and we just couldn't get him through that, and he deteriorated. And I remember the only people with him were the nurses, who were great and very fond of him, and myself. And I remember sitting with him, which is not always usual, because the doctors often aren't. We end up being called elsewhere, and we're often from one patient to the next. But I do remember, I think because I felt he was particularly mine, I'd found him on an outlying ward, and he'd come back to my ward, and he told me about his family. I remember sitting with him at the end, and I remember thinking he had no one to sit with him when he was dying, apart from us. And I did remember thinking just how vulnerable he was, and how, if at the beginning of his treatment options, I had to say that the state allowed him the option of palliative care, or that he could take his own life, then perhaps he would have thought, maybe that doctor thought that was the best thing to do. Maybe that doctor thought that was the right thing to do. And I suppose I am so hugely concerned that a man like him might just think, I think those doctors and nurses think that this is the best way forward, and I don't really want to be a burden. And so I guess I'm really concerned that patients, particularly like him, who are more vulnerable and don't have a daughter-in-law, fighting for their corner and saying, of course, we'll come up and visit you, we might just think that they were a bit of bother, and that they should just really take their own life. And so I suppose my real concern is that that should never happen in medicine, and that we as a society should be there for the most vulnerable and for those who are dying. And I suppose I think at the very end of the day that saying to someone that it's possible for them to take their own life, and that the state will assist them in that, really undermines the value and worth of them as a person. Next slide, please. One of my other concerns is when you look at other jurisdictions, it's clear that virtually every guideline has been breached or violated. And this, although you'll hear Mr. MacArthur talk about safeguards, it's almost universal that safeguards have been breached. Next slide. So what I've been working on over the last year or so is a campaign of healthcare professionals, because I feel we are in a particular position to say we don't want this in the way we work. We don't want this in the way we look after patients. Next slide. And so this is really just a summary of what I've mentioned already about trust, vulnerable people, and the lives of disabled and dying people having value and worth. Next slide. This is just an example of other jurisdictions in Oregon. Over half the people in Oregon said that feeling a burden was one of the reasons they wanted assisted suicide. And I think my real concern is that the terrible irony is that patients that assisted dying will reduce the autonomy of those who are the most vulnerable. Next slide. And although some of you may think this may be conjecture, I think I was most concerned to read that in Belgium, they now have instances of involuntary euthanasia. So that's when the doctor actively kills the patient by lethal injection. And that occurs in 1 in 60 total deaths in Belgium in 2013. And it actually accounted for 1 in 4 of all medically assisted deaths. So 3/4 were those who were voluntary, and 1/4 were involuntary. And so I'm just incredibly concerned that what starts off as being acceptable and voluntary, and for those who have capacity, turns into those who are frail and elderly and those who have dementia. Next slide. So I suppose I want you to think a little bit about how difficult it is at times for people facing the end of life, but that assisted dying is not the answer. And I think Cicely Saunders put it really well in what is the next slide, when she said, you matter because you are you. So that is the dignity aspect. And you matter until the end of your life. So not when we can help you to take your own life, but to the end of your natural life. And she said, we will do all we can, not to help you to die peacefully, but also to live until you die. I think there's one more slide that's coming. So I guess I just wanted you to have a sense of the fact that assisted suicide, or assisted dying as it's been called, is actually a really big issue for Scotland. It is the big medical ethics issue, big moral issue coming before the Scottish Parliament over the next year. And I would put to you that our autonomy is not absolute, and that compassion, although worthy, it's a really important motive, it doesn't justify intentional killing, but instead should drive us to excellence in palliative care. Next slide. So the question is what we can do. And one of the things that's really important is that we can all, as individuals, respond to the consultation that Liam MacArthur has started. He launched it about 10 days ago, and it's running till Christmas. So there's no pressure on time. It's fairly long, but it is explanatory, and you can respond as an individual and just say what you think are your concerns about having this in our society. So that's one thing you can do. I think Paul will send us out these websites, so you don't need to worry about taking them down if you're interested. The next thing we really ask you to do would be to write to it should be your MSP, particularly at the moment, and also to the House of Lords. So although Liam MacArthur is putting a bill through Holyrood at the moment, well, it's going to be launched next year, the consultation comes first. There is a private member's bill in the House of Lords at the moment. It's called the Baroness Meacher Bill, and that's actually in the House of Lords and has a second reading on the 22nd of October. So if you felt so minded, we'd be so excited and grateful if you would write to your MSP and to a peer. You can choose a peer, any peer you like. And I find a helpful way to do that is through this website called theyworkforyou.com. And the next slide is really if you would like to be involved, or you would just like to be kept up to date, or if you'd just like to be supported in some of this work, then Care Not Killing is the umbrella organisation. I work for them, and that's for all of us. But our campaign in particular is Our Duty of Care, and that's for healthcare professionals. So all of us, so doctors, nurses, dietitians, physiotherapists, medical secretaries, anyone who's connected with healthcare. So if you know anyone who's connected with healthcare, then that would be brilliant to forward that website to them. And we have a letter on that website at the moment that we're sending to the health secretary that we'd love anyone who has a connection with the NHS to sign. So it's been a real pleasure for me to give you a few of my thoughts about this really, really hard topic in a way. And I really hope that you might have some questions or comments, experiences that you might be able to share with everyone else. I'll do my best to answer, or if I can't, I will find out answers to your questions as well. But many thanks for your attention, and thank you for your time, albeit by Zoom. I really appreciate that. Thank you.